what Dr. Anirudh has defined. He has very clearly, beautifully shown you a lot of pictures of OCT angiography where it is useful in cases of uveitis. In my talk, I'll be talking to you about the wide field OCT angio. That means we are just broadening the images, as we all know that uveitis is not just restricted to the posterior bone. So coming to the financial disclosures, we at Karevala Institute are a part of this international collaboration by ZEISS, which is the ARI network. And so when it comes to uveitis, you know the clinical suspicion is the most important, but multimodal imaging helps you to confirm your diagnosis. Fluoresceins and ICGs, they assess the alterations in your blood-retinal barriers, and they study the choroidal perfusion as well for you, specifically the ICG. But the basic disadvantage remains that these tests are all invasive. So then came these non-invasive OCT angios that offers you in vivo layer-to-layer dissection. But the major drawback so far was that there were a lot of artifacts, very limited view, and the inability to visualize your peripheral retinas. And then came these swept source Plex Elite models that are now offering you 12 by 12 mm montage that will come as compared to the standard 3 mm or 6 mm scans. You can see up to 70 degrees of your retina, which is 9 times to that of what a 6 mm scan is showing to you. So in the next few minutes, I'll be taking you through these various clinical scenarios to understand this utility of this fancy device. So this is one classic example. Dr. Anirudh has beautifully shown the use of OCTA when it comes to serpiginous like choroiditis. So as you can see up here, the 3 mm and 6 mm scans, you're missing most of the lesion, but OCT angio montage picture on your extreme left, it clearly depicts that there were 2 or 3 different lesions that you need to watch for. So it gives you a complete picture of your pathology, and it also helps you to understand the level of disease activity, that is whether your disease is in an active stage, healing, or it has already healed. The picture on your right is suggestive of these active choroiditis, which appears as hypoflow due to an inflammation or an ischemic event that is happening at the level of choriocapillaries, whereas as once the lesions becomes more inactive, there's a lot of choriocapillaries loss, RPE loss, that results in the appearance of these medium large choroidal vessels becoming more prominently visible. It's an example of this lady with a tubercular choroiditis. It's an active lesion at the inferior mid-periphery, which you can see pointed out with the white arrow. But as soon as you run your OCTA standard scan, there's nothing much that you can see. But on an OCT montage, this lesion is very clearly visible, and you can see the hypo edge at the lesion, suggestive that it is an active pathology. And 3 weeks after treatment, the same lesion shows signs of healing, as that little flow void that you used to see earlier is kind of disappearing. It's a case of VKH, where again the choriocapillary slab shows the distribution of multiple hypospots, suggestive that there is an inflammatory foci going at the level of choroid and choriocapillary. This is taken at the level of choriocapillary slab, and following your systemic immunosuppression 3 months later, the picture looks much more beautiful because these hypospots are reducing. This is interesting. It's a 35-year-old lady with headache, tinnitus, and blurred vision. The fundus shows some dull FR, very elevated macula in the left eye, and OCT shows a generalized elevation of the RP with presence of some subretinal fluid. We did an FFA, except the hot disc and ill-defined little leakage. There's nothing much that could be inferred. We did an OCT angio, and that was able to pick up these tiny little spots of inflammatory foci, which was picked up at the level of choriocapillaries. And more interesting was OCT angio 1 month post-steroid treatment, which showed the disappearance of these hypospots. And OCT shows flattening of the RPE dome with disappearance of the subretinal fluid as well. This is what we presented in OSLI 2017. It's a sympathetic ophthalmia. Serial OCT angio images shows a remission of the disease following the treatment. From choroiditis, let's move one step further, which is a retinochoroiditis. That means toxo is the most common entity that we usually commonly see. Here again on color picture, you can see a fresh toxo lesion near the fovea. And since the site of involvement is usually retinoporoidal, so your superficial and deep capillary plexus will show abnormality also, as seen up here, as little areas of lost architecture, could be hypoarea, could be an inflabbicus blockage, could be inflammation. Can't really comment on that part yet, just visible as a hypoareas on SCP and DCP slabs also. So it helps you to differentiate between toxo and tubercular. As in SCP, DCP slabs will not pick up any significant abnormality if your lesion is at a little deeper level in the. Moving on to this to retinitis. Again, there's a juxtafoveal patch of retinitis which profusely leaks in the late phase of your fluorescein angiogram. Since the lesion is involving the superficial retinal layers, OCT angio depicts flow void in the SCP and DCP areas, but your choriocapillary slabs and the deeper choroid seems to be all clear. So after ruling out infective causes, patient was given steroids under the cover of antivirals. The subsequent OCT shows this remarkable improvement, and so was the color fundus photographs. This is a case of dengue maculopathy. Again, retinal infarction is picked up nicely on the deep capillary plexus slab of OCT angio. Now moving on to the vasculitis, it's a 28-year-old with bilateral peripheral vasculitis. FFA shows CNPs and NVE fronts, as the 6 mm OCT angio will not give you much of an information qualitatively, and wider OCT angio depicts these areas of non-perfusion. And also monitoring becomes a little easy, as you can see your PRP scars also pick up any new area of non-perfusion or NVE which might develop in the future in a non-invasive manner. Moving on to intermediate uveitis, here Whitefield OCT has failed to give us any useful information. Probably some quantitative parameters will come up in the future. As you can see, right and left eye FFA gives you a contrasting picture, where retinal periphlebitis and CMO is so easily seen in the left eye. The OCT angio scans didn't tell us much. This is the last section, which is an inflammatory CNVM, bilateral PIC lesions seen on OCT angio as well. A bit more importantly, if you look carefully, the color picture shows a retinal hemorrhage. Corresponding OCT angio is able to pick up the CNVM. And so just to kind of conclude it, imaging has 3 key roles. One is to detect, then diagnose, and also to monitor. And these OCT angios being non-invasive helps you to do it in a much more patient-friendly way. There's much more quantitative parameters yet to be discovered on OCT angio. So we'll wait for all that to happen till next session. Thank you. Bye-bye.
Thank you, Dr. Manpreet. I think OCT angio is a new revolution in the make, and everybody's working on it. Any questions from the audience on that? Okay, so that I request Dr. Nitin to please give a momentum to Dr. Manpreet, please.